I guess, New York University in 1983. I don't really know enough about him to tell you any decent introduction. But last week I was talking with one of the people who works with a lot of AIDS patients at ECMC as a dental hygienist. And she said that, you know, you doctors, there comes a point when you guys really can't do very much for your patients, but we can. You know, the AIDS patients, after a while, their mouths get kind of scuzzy, and they don't want to smile because their teeth look disgusting, and they don't want to kiss their friends because, you know, their breath is terrible, and we can fix that. And so we can do something for them that maybe you guys can't. And I assume Ross is going to talk to us about some of the things that maybe we can do.
Very sorry that I was late this evening. It was really difficult getting out of the city with the weather, but I made it. I see this is not a place to own a bicycle. But I'm very happy to be here, and hope that I'll try to be able to answer many of the questions that you probably have. Every fall, we organize a conference on one particular aspect of AIDS. This past year, we had over 40 different presenters. We had 24 different workshop sessions, etc. So to boil down AIDS into a one-hour presentation is actually a pretty difficult thing to do, but I'm going to do the best that I possibly can. The first thing that I have to say is that, you know, when I first started out, I wasn't an AIDS specialist. I was just someone who was very interested and concerned about a problem and a disease that nobody else seemed to be concerned about. And I saw some of the first AIDS patients in New York City while in medical school, and spending time in the wards of Bellevue Hospital in Manhattan. And of course, at that time, it wasn't called AIDS. We didn't know what it was called. But we definitely knew that something new and unusual was happening. And I went to a conference on AIDS several years ago, and one of the speakers defined an AIDS specialist as someone who has seen 5 AIDS patients and willing to see more. And that's very, very true. It does not take a tremendous pool of knowledge, even though I am going to try to impress you tonight. It takes really a concern and a commitment. And if you, as a healthcare provider, will bring that to this group of patients, the rest will come with time. The expertise will be there. But the compassion is a very important part of the overall care that we provide. Is AIDS a new disease? The answer is yes. And what evidence is there to support that notion? And there are a number of evidence, but the best evidence is the fact that unusual infections were happening to previously healthy individuals. And this is the article that first reported a series of cases of pneumocystis carinii pneumonia and mucosal candidiasis in previously healthy homosexual men. This appeared in the New England Journal in 1982. But in fact, the first case of AIDS in the United States occurred in 1978 in New York City. Okay, next slide. This is from 1983 in Newsweek, and of course, the coverage hasn't stopped since AIDS became an issue. And the media has, I think, at times played a detrimental role because it's raised probably more fear and more concern than perhaps there should be. But clearly, it is a serious problem. It is an epidemic by any way you define one, and something that I think finally is getting the true attention that it deserves. The one thing I have to say about this slide is very interesting, of course. They have a tube of blood here that's labeled AIDS, KS. We don't label tubes like this anymore. So that's a very important, interesting historical perspective. We have universal precautions now, so we treat every sample as it potentially has HIV. Of course, we do wear gloves when handled. Okay, next slide. HIV is now a global problem. These are World Health Organization statistics. 1 in 75 men in North America is HIV positive. 1 in 700 women. In Africa, 1 in 40 men and 1 in 40 women is HIV positive. In Europe, it's a little bit better, but 1 in 200 men is HIV positive, 1 in 1,400 women is HIV positive. These are much more common than rates for cancer and a number of other diseases in the population. Next slide. These are cases by risk factor reported in the United States just in the 1-year period between August and July of this past year, just to give you an example of what kinds of cases are developing. Gay and bisexual men still account for the majority of new patients that are being reported. Intravenous drug use is very important, and now heterosexual transmission is becoming an increasingly more important factor. In this 12-month period, it was up to 7% of total cases, and that percentage, while still small, continues to increase. Okay, so this is in that 12-month period. Almost 43,000 cases were diagnosed. Okay, the CDC is about to change its diagnosis of AIDS, the definition of AIDS, and that will be one that is pretty much deals solely with T-cell counts, which I will talk to you about, and gets away from defining a case of AIDS as someone who has had one of a number of potential complications of the disease. I think that will lead to some important identification of how severe the problem really is in the United States. Okay, next slide. AIDS, full-blown AIDS, is a reportable disease. It's mandatorily reportable to the state health department. There is a confidential process for doing that. Most hospitals will delegate that responsibility to their infection control department. But it is, in fact, the physician's legal responsibility to see that the case is reported. This is the cases reported from the 8 western counties of western New York, including Wyoming County, and of course the city of Buffalo. Here we are in 1990. It's felt that the data is pretty good up to that point. 1991, the data is still incomplete. But clearly we've had an increase in new cases total, and although it's leveled off somewhat. And it's important to say that this is the reason why my services have been needed so greatly for our area. Okay, next slide. At the AIDS Designated Center at ECMC in our clinic, I have been there now for 6 years, and during that time I've collected some statistics which I have shared with you today in the handout. Some of these are going to be seen in the slides today. We've seen a total of 620 persons who are HIV positive from 1986 to September of 1991. The distribution is, you can see 115 of them were women, 505 were male. Next slide. So we are seeing a substantial number of women, especially in the past 2 years. This is their diagnosis at their first visit when they see us, and I'm sorry, this is for my faculty practice, which is also located at the hospital, which is through the university, and this is an additional 300 patients to the 620 I already showed you. So we've had experience with approximately, and we're now over 1,000 patients at our center. Next slide. These are patients from the community. If you look at the mortality, of course, AIDS is a very serious disease, and we have 151 known deaths out of our population. Most of our patients that we have seen in the past 2 years are still living, however, and 60 patients have been lost to follow-up, and we presume that many of these patients have also died. Okay, next slide. You can also see by these numbers that they have grown over time. This is the faculty practice where another 95 patients have known to have died. So we've got about 250 deaths from AIDS at least that I've been directly associated with in Western New York. So it is a very sobering and serious problem. Okay, next slide. Well, one of the first questions is from a patient, how long do I have to live? Okay, I get asked this all the time. And the statistics on that are changing, and I generally do not like to quote specific statistics because I am not Swami and I cannot predict on an individual basis how long anybody is going to live with the disease. But I can share at least statistical averages and bell curves. And one of the interesting things is that women with AIDS survive for a shorter period than men. These are out of New York City in the Bronx, and these are patients who were never treated with ACT or any other special preventative measure, things we do now. So this is a good baseline to compare future statistics to. But you can see that 50% of the women had died by about 8 months after an AIDS diagnosis. The men, it was slightly longer, about 12 months. So we've done much, much better than that, as I hope to show you. Next slide. One of the interesting things, phenomena that we have in Western New York is one that I call homecoming cases of AIDS. And this is likely the kind of patient that you might see and end up here in this hospital. And that is someone who has already been diagnosed with AIDS in another major metropolitan area, but whose family lives here, who comes home for a number of reasons. Either they have poor health and they need the help of their family just for daily living. Sometimes they just run out of money, they lose their job, etc., and they return here. And sometimes they're just terminal and they need to die where their family is. So I would not be surprised if you have seen patients that they are of this nature, ones that already come to you in very late stages with a diagnosis of full-blown AIDS, many times in a terminal condition. Next slide. HIV, the virus, was finally isolated in April of 1984. By March of '85, we had licensed the first antibody test to detect the virus. This is an actual electron micrograph that shows the virus budding off of lymphocytes in culture, and you can see the budding particles down here. It requires a human cell for its reproduction. Next slide. This is a schematic diagram of the virus. The virus has a conical shaped core. It contains 2 strands of RNA, 2 molecules of a special enzyme called reverse transcriptase that I will talk to you more about. It contains a shell protein. This is called the P24 protein. It contains a transmembranous protein called P41 and a envelope or outer shell protein called GP120. And each of these proteins are very, very important for the virus's overall replication. And I hope we get time to share some of that with you. But scientific knowledge about the nature of these proteins, how they work, how they're regulated, how they interact with the immune system is extremely important toward moving to a search for a cure. Next slide. Well, I am going to show you how the virus reproduces. Basically, the virus attaches to the outside of a cell. The spikes here are actually the GP120 proteins simulated. The envelope, and through that P41 protein, the membrane of the virus actually fuses with the membrane of the human cell. At that point in time, its contents are released into the cytoplasm. There, reverse transcriptase, its own enzyme, starts to go to work to change that RNA or to make from that RNA double-stranded DNA copies. These copies are then incorporated into the genome or the chromosomes of the host cell, and through a very complicated series of maneuvers that are not completely understood, the cell is then directed to make almost solely HIV proteins. Okay? These proteins will then assemble, new viruses will bud from the cell, and that is how the infection continues. Reverse transcriptase becomes a very important enzyme because it is the target of most of the drugs that we use right now to treat the infection. Okay, next slide. Well, if you were a virus and you wanted to disrupt the human immune system, you would pick the T4 or CD4 lymphocyte, and that is exactly what the HIV virus has done. The T4 cell or the CD4 cell, the names are interchangeable, and I will use both of them this evening. That cell is the most important cell in the immune system. These cells are white blood cells, but there are a number of different kinds, and the T4 cell is central to the function of all of these other cells. So in order for B cells to make antibody, the T4 cell has to give it proper signals. In order for macrophages, which are many times the first cell that sees a foreign object, the macrophages have to talk back and forth with the T4 cell in order to get an immune response going. There are natural killer cells that have to work with the T cells, and T cells have ways of amplifying their own responses. So the virus has found the target in the immune system as a way of preventing the immune response to itself. Very, very smart and very impressive organism. Okay, next slide. One of the things that happens is that the virus, after infecting the cell, may not reproduce right away in large amounts. It may only reproduce in very small amounts. But something happens in a T4 cell that stimulates that cell, and with that stimulus, the virus then takes over the production in that cell. What is the stimulus that causes the viral replication to increase so markedly? We don't know. There are many possible and theoretical possibilities for that. In the laboratory, we can put something called phytohemagglutinin, which is a very common laboratory chemical used in cellular research. And after T4 cells are infected, we can stimulate them to become activated. When that happens, they start to reproduce virus. They release that virus. The cell is usually killed in the process, and then you've got virus available to undergo a new round of viral infection. And what you have is a pit, basically, a cycle that just goes downward to the point where you use up all of the T4 cells that you have, or most of them anyway, and at some point in time, without enough of these, you start to have immune dysfunction, and that will lead to the symptoms and the complications of the disease. So what the factors are that create this is one of the very intensive areas of research at this time. Okay, next slide. In the body, this is a diagram of some of the immune responses in the body. In the body, when a human is infected with HIV, the virus can be found within the person's bloodstream for about 6 weeks, very actively. It's very active for about the first 6 weeks. At that time, the body is creating an antibody response. The dot and the diamond on this diagram are antibody responses. The antibody responses also occur pretty much within that first 6-week period of time. Some people take a little bit longer, but most people will develop an antibody within 6 weeks. At the time that reaches a certain level, probably antibody is starting to affect an immune response, and so the virus becomes virtually undetectable in the blood. The virus itself becomes virtually undetectable in the blood for many, many years. At some point in time, and again, the stimulus is not known, but one of the proteins starts to decline, and the virus starts to become more active, and we believe that this is about the same time that active symptoms of the disease develop. Okay. Next slide. All right. But there's even more bad news besides all that, and that is that once the virus is in the individual, it adapts. It adapts to that individual over time, gradually, in a selection process. A more virulent strain, a stronger virus, is the result 2 to 3 years down the road, once symptoms have started, than the infecting virus. And this has been shown by taking viruses from an asymptomatic patient and then taking viruses from the same patient after they've developed AIDS. The second virus is much stronger. It grows in more cells in the test tubes. It grows to higher titers. It grows faster. It spreads more rapidly. And it even has a better way to avoid the immune system. So the virus it's a constant interaction between the person's immune system and the virus. And in the end, usually the virus wins. Okay, next slide. All right, well, what is it like for a person to have AIDS? And I want to share with you a story of one of my first patients with AIDS that I've made some theoretical suppositions for teaching purposes. But this is a patient whose name was Teresa, and she was 30 years old back in 1982. And at that time, she gave birth to a second child that was a son. And her husband was an intravenous drug user, and I'm going to theorize that she was infected after the birth of her son, because both of her children have remained healthy. But it's possible that, in fact, she was infected before her son was born. At any rate, she started to lose weight without dieting. She was a very obese woman. She weighed about 220 pounds or so. And she started to lose weight, and that was really her only symptom. And she was actually pretty happy about that, having been so heavy. But eventually, and this is when I first came to know her in 1984, she was admitted to the hospital with an unknown pneumonia. She was, I don't know what we treated her with at the time. It was not pneumocystis because we really looked for it, could not find it. But she got better, and we diagnosed her as having AIDS-related complex at that time. She began having problems such as recurring genital sores. By the time, in early 1985, the HIV body test became available. We tested her, and to no surprise, the test was positive. She developed thrush in that year, and then in early 1986, she was admitted to the hospital. We diagnosed her as having pneumocystis pneumonia. She told us that she wanted her mother to raise her children, and she died within 2 weeks. This kind of scenario should not happen anymore. We've made enough treatment advances so that back at this point, when we were losing weight, a good history would have picked up a risk for HIV, and we would have tested her at that time, and she would have had a very different course than this. So we have come such a long way with treatment advances. Next slide. This is going to change, of course, but when you're looking at CDC-defined AIDS, the official cases that the health department reports, etc., that's literally the tip of the iceberg. It's estimated that there are 1 million to 1.5 million infected individuals in the United States. We've had, about 190,000 cases of AIDS. So perhaps 20% of the potential population has reached that stage that have HIV. But what that means, we still got 80% to go. So there's a lot more people out there with HIV that are that are going to become sick in the future. Okay, next slide. How long does it take for someone to develop AIDS once they've been infected? And it's actually a very variable answer, and there are a number of factors that I think I'm going to discuss with you shortly. But the best information we have is the San Francisco cohort. This was a cohort of gay men that was organized in the original trials to test the efficacy of the hepatitis B vaccine, because gay men are at a very high risk for hepatitis B. And in that study, they were given the vaccine, and then they were serum was taken every 6 months to look for antibodies to the vaccine, and it was frozen and stored. And that trial began in 1975. So they had a lot of samples. There were 5,000 men in that study to look at the efficacy of the vaccine. And so there were a tremendous number of samples that were available. And once HIV testing became available, they went back and they tested all of the samples they had in their freezer. And they found the first samples became positive in 1976. Okay? And so from 1976 till today, they have followed, they basically know the 6-month period of time in which the person was infected. And from that time estimate, they have been able to estimate the time it takes to develop AIDS, and this is their results. That in fact, 15%, only 15%, had developed full-blown AIDS after 5 years of being infected. And that it rose to about 50% after 10 years, and this cohort's now been studied for 13 years. I don't have all the exact data to share with you today, but the point being that you can live with HIV for a long period of time before you become sick, before you become symptomatic. So you do not, in fact, know if you are HIV positive unless you are tested. You do not know if a patient is HIV positive unless they are tested. And testing is not 100%. There are false positives and there are false negatives. So relying on a policy of testing to identify who's got it and who doesn't really does not make sense for that reason, and for the fact that people are continually becoming HIV positive. And so how often do you test somebody before you can say that they're not positive, etc. Especially when dealing with blood samples, doing procedures, etc. And thus the genesis for universal precautions. Okay, next slide. What are the factors that cause one person to progress faster than another? They're not all well understood, but it is clear that it is a complex situation, it is not simple, and that a number of factors probably interact. Quantity of lifetime viral exposure appears to be important. The more virus you're exposed to, the faster you develop AIDS. This is true because for a couple of lines of evidence to support this. The first is that the initial patients who came down with full-blown AIDS were people who were very highly sexually active, had a very high number of sexual partners, and thus, very early on, AIDS gained that promiscuity label, etc., and all of the ramifications that go along with that. Another way is that if you look at blood donors who were positive unknowingly before testing began, if you look at recipients of those donors, the donors who developed AIDS faster, the recipients also developed AIDS faster. And as you go on in time of the disease, there is more virus circulating the further out you go. So those people received a higher inoculum of virus at the time of their contaminated transfusion. So quantity is probably very important. Strength of the immune response is very important. It's influenced by a number of factors, including genetics, nutrition, age. There are certain HLA types that appear to be related to faster progression than others. The virulence of HIV itself is very important. As I mentioned, In an individual, the virus gets stronger, gets more virulent. If a virulent virus is transmitted to another person, that person is going to develop AIDS faster. But by the time I get to see a patient, all of this has already taken place. What I can do is I can prescribe antiviral drugs. I can give medications that prevent opportunistic infections. And so those are two very active things that I can do to slow down the progression of the disease. And finally, there are probably unknown cofactors that I'm sure will still come around as time goes on, perhaps including some of the various proteins that are involved in the immune response itself. Primary care is very important for HIV persons, especially those who are asymptomatic. Not everyone who is HIV positive needs to come to see me. A primary care physician can handle a great deal of at least early HIV disease and should be able to handle that load. Editorials to that effect have been published in the Annals of Internal Medicine as well as in the Journal for Family Practice. The goals of primary care are very straightforward. We try to prolong survival time. We try to minimize the complications of the disease. We try to prevent further spread of HIV, which is a very important role that we can play, and to maintain and improve the quality of life, whatever life these patients have left to them. Next slide. What I want to take some time doing with you now is presenting a framework for primary care. The first thing you have to do is you have to stage the person. You have to know where their HIV infection is, how much either immune function or damage, depending on whether you look at the cup as being half full or half empty, where is that patient along that continuum of the disease. With that, you'll be able to formulate a very broad prognosis. You'll know when to start anti-HIV therapy, and you'll know when to decide to start prophylaxis against pneumocystis and perhaps other infections that come along. Okay, next slide. The baseline evaluation that we conduct for HIV infection is pretty straightforward. We conduct a detailed history and physical examination. We do a PPD with controls. We do T lymphocyte subsets, which can be ordered. All reference laboratories now carry them. We do a CBC, chemistry panel, syphilis testing, a toxoplasma titer, hepatitis B markers, and chest X-ray. The T cell count is the most important test in that battery. It tells you where that person is. What is the evidence for that? The evidence is, again, in the San Francisco cohort, where if you looked at the T cell count, the average T cell count, T4 cell count, that it did correlate to their overall disease state. So at 800 T cell count, which is normal, that person will be, in fact, asymptomatic. By the time, and a normal T cell count is about 800 to 1200. Most of us have a T4 count in that range. Although the reference labs will give you normal anywhere from 500 to higher, that's that 95th percentile at the edge of the bell curve. But most people have around 800. By the time people are down in the 500 range, they've developed lymphadenopathy or swollen glands. By the time they become symptomatic with age-related complex, they're down to 350. And by the time they develop full-blown AIDS, they're down to 200. So they've gone through a tremendous amount of reserve. So the immune system does have built into it a tremendous amount of reserve, and it's that reserve that keeps these people asymptomatic for so long. Okay, next slide. In terms of estimating a short-term prognosis, you're going to use your laboratories to try to do that, and you can't say definitely that if AIDS is not already present, if there's CD4, their T4 cell count is less than 200, they have a much higher risk of progression to AIDS. If their SED rate is abnormal, over 40, if they're anemic, less than 12 grams at the time that you first evaluate them, And if you measure a viral protein called P24, which we do at ECMC, we have that test available to you. If that is detectable, that is also a poor prognosis indicator. It's pretty straightforward. Next slide. P24 antigen levels are very, very interesting, and we're still learning how to use this test in clinical practice. But one thing is very clear. It is a subset of patients who become P24 positive. It is a viral protein. It's that shell protein I showed you from the original diagram. If they become positive at some point in time, it is felt to be an indicator of a higher activity of viral replication. There's more viral replication going on. Even during the time at which they were P24 negative, you can see that over time, their T4 cell count has declined much faster than those people who are consistently P24 negative. So a P24 antigen is a poor prognostic sign. That's about as much as we can say with it right now. And what's happened is that once they are P24 positive, we can follow this response to treatment, and that gives us some indication of how successful the treatment is. Okay, next slide. There's no possible way I can teach you all of the complications of AIDS in one night. So I'm not going to try to do that. I'll show you a few things, but I'm really not going to try. What I do want you to know, however, is that HIV is a multi-system disease, that it in fact can affect any organ system in the body. The ones it more commonly affects are the ones that are barriers to the outside world. So your skin, your lungs, your GI tract, those are going to be the most commonly affected. However, the brain can be infected. You can have encephalitis and meningitis. People can become demented as a result of HIV disease. They can develop retinitis of the eyes, which can lead to blindness. Malnutrition, diarrhea can be very severe in the GI tract. Pneumonia and fibrosis in the lung can develop, resulting in, these are severe disabling diseases, complications that can occur. Let's see. People can develop severe pain syndromes. They can develop muscle inflammation. The heart's left off this list, but they develop cardiomyopathy. Really, any organ system can be involved. So they say that to know syphilis is to know medicine. That was the old Osler theorem. But nowadays, to know HIV is to know medicine. And in fact, doing this work has made me just a very good general internist, I think, as a result. Okay, next slide. At least I would like to think so. I'm not a pediatrician. I do not treat children. We do. Children's Hospital in Buffalo does have a program to treat HIV kids, but for those of you who may see children, what does a congenitally infected child display in terms of symptoms? And this was a study that was presented this summer at the International Conference, which looked at children who were born to women who were HIV positive. 23 of those children turned out to be truly infected. 48 were called seroreverters. That means they tested positive because they had their mother's antibody, but not being infected, they lost their mother's antibody over time. And they were normal, healthy children. So they're seroreverters, and 85 control children. And what they found in comparing these groups is that infected children developed an enlarged liver or spleen by 1 month of age. By 2 months of age, they failed to gain weight. They have oral candidiasis, so they start looking like a failure to thrive baby. And then by 3 months of age, they have abnormal motor development. And by 5 months of age, they've got lymphadenopathy. So these are some of the signs you can look for in young, in infants with HIV infection. Okay, next slide. In women, an important complication is cervical dysplasia and neoplasia. Women with HIV have a tremendous incidence of abnormal pap smears, over 35% of them, compared to 3% of the normal female population. That cervical dysplasia is much more prevalent. It's often related to human papillomavirus, and if they develop neoplasia or invasive lesions or pre-invasive lesions much faster, and when they do, they're much more severe, and women with HIV are actually dying of cervical cancer. So an annual pap smear is recommended by the CDC. We do pap smears every 6 months at ECMC with our women. Okay, next slide. We follow that up with colposcopy, etc., for abnormal results. So we're very aggressive in assessing that particular problem. This is a classic case. It's from 1985. It's one of the classic cases of a complication that you should all recognize. This is a patient who presented with fevers that developed over a 2-week period of time. First they were low grade, then they started becoming 102, 103. They developed a non-productive cough and significant shortness of breath. At first it was just going upstairs. Later it was very severe shortness of breath. At the time they were seen in the emergency room, a chest x-ray revealed diffuse bilateral interstitial infiltrates. You notice that they're centrally located, that the periphery appears to be spared somewhat by this process. This patient underwent bronchoscopy and pneumocystis pneumonia was diagnosed. This is a very classical x-ray presentation of pneumocystis, so I had to show it to you. Next slide. Within 4 days, despite therapy, appropriate therapy, the patient worsened. Their infiltrates became more diffuse, more to the periphery, as you can see here. But this patient ended up on a mechanical ventilation, but survived. Okay, came off the respirator, out of ICU, and survived. Okay, next slide. Okay. I wanted to show you Cmv Retinitis because it's an important complication. It's something that you should not miss. You do not want anybody to go blind if you can help it. It doesn't take, I mean, even I can see a lesion like this, and I'm not an eye doctor. I do eye exams on my patients. I see some funny spots. I send them to the eye people right away. I cannot fool around. Okay, next slide. Any symptom of blurred vision, etc., right to the eye doctor. You do not fool around with visual complaints in HIV patients. This is a lesion of, well, can we focus that a little? Does it focus any better? There you go. This is a Kaposi sarcoma lesion. It's a very large lesion. Typically, this is a more typical lesion here. This is probably a very early lesion here. If you had something like this, you'd think it was a bruise or something like that, a mole perhaps, but it doesn't stay the same. It gets worse. It gets harder, raised, purple, and can you tell that there's a kind of a ecchymotic halo around it, as if it were a bruise? That is, in fact, activity in that area of the skin, and this is a much more advanced lesion on one of my patients. But I showed it to you because too many times I've had people with Kaposi sarcoma not diagnosed right away appropriately. So you see a funny lesion, single male, age 35, not married, get him biopsy. Get him to a dermatologist. Okay. Or do it yourself. Many of you probably do punch biopsies yourself.
This could also be like a melanoma?
It almost looks like a melanoma, doesn't it? Except it's very purple. It doesn't show in this slide because the whole slide is yellow and the lighting isn't perfect. But it's very purple, and melanoma is going to be a little browner. But, you know, if you don't know, sometimes I biopsy things that I thought were melanoma. Came out Kaposi sarcoma. So even I've been fooled, and, you know, you wouldn't take it should never get this far, is what I'm trying to say. It should be a small lesion like this that you should do the biopsy on. Okay. It shouldn't get that far. All right, next slide. But I did want to show you that. Here's a very common oral. We gotta focus this again. I'm sorry, this is not an auto-focusing projector. Anybody know what this lesion is here? Okay, we have all the dentists in the audience.
Dentists, the doctors.
Well, very good. Because, you know, many times it's actually the dentist that picks this up first. And the dentist can be the first office where HIV infection can be diagnosed. If you see this, it is HIV until otherwise proven. Okay. This does not scrape off. It's not painful. It doesn't hurt. You may think it's thrush, but it's not thrush. It is hairy leukoplakia. Okay, next slide. Very typically, it's on the lateral margins of the tongue. Okay. This is something hopefully you would never have to deal with, but this is one of the results of keeping people alive longer with HIV disease. What we are starting to see is a secondary epidemic of non-Hodgkin's lymphoma in people who have lived with full-blown AIDS for 24 months, 36 months. You can see the incidence starts to increase. This is cumulative probabilities. So that non-Hodgkin's lymphoma is something now that we're struggling with because these turn out to be very aggressive lymphomas, very often minimal response to chemotherapy and radiation. Okay, next slide. So to cure AIDS, we're going to have to cure cancer at the same time. Okay. So that gives you some idea of some of the complications. I think I put others in. Hopefully, I put others in your handout to give you some guide. But like I said, any organ system can be involved. What we have learned over time is that so many of these complications and infections are preventable. They're preventable through prophylactic medications. Pneumocystis is now preventable with aerosolized pentamidine or even Bactrim. Candida is preventable through antifungal medications. Toxoplasma, we are involved right now in a study to see whether or not pyrimethamine is preventable for toxoplasma. Bactrim appears to have a preventative effect. Herpes infections are preventable with acyclovir. Tuberculosis is always a preventable disease in someone who is PPD positive with INH. So we can prevent complications of the disease, and we're getting better now at knowing when to start some of these medications before these patients ever develop these complications. Next slide. So part of the thing is looking at prevention. This is the setup to deliver aerosolized pentamidine. This is a product called the Respigard nebulizer. It's available at any health health supplier, distributor, etc. A nebulizer chamber, we dilute the medication in 6 cc's of sterile water. It's put in a nebulizer chamber that's connected to an oxygen source. Through a series of one-way valves and a particle filter, the aerosolized particles are then directed toward the patient with a mouthpiece for inhalation. And this is a very easy thing actually to deliver. We have many hospitals actually do this like in their emergency room or in some other room in the hospital. And we can also do this through home care companies as well. So we have patients in all over the 8 counties who actually have this stuff all delivered to their home and it's done at home. The first treatment must be done in a supervised setting, however. Counseling is a very important part, is another very important part of the care of these patients. And we counsel them about safer sex. Now, most doctors are not comfortable with talking about sex. They don't tend to ask too many questions about it, etc. But we talk about sex. We encourage the use of condoms, including during oral intercourse. We advise people to reduce the number of sexual partners even if they do use condoms. We do advise them to avoid anal intercourse. We advise them to do things that will make sex perhaps fun but not penetrative, such as dildos, all kinds of wonderful things if you're creative. And we definitely ask them to avoid psychoactive substances. If you are drunk, you are not going to put on a condom. So we talk about this, and I don't talk about it on every visit necessarily, but periodically I do talk about it. I say, well, how are things going? How's that relationship going? Are you wearing the condoms, etc.? It's something that you do have to talk about and bring up. And you should not be afraid or ashamed to do that. There are so many issues that come up, psychological and social issues with the disease, the stigma, all of that stuff. The fact that it is a disease that usually results in the patient's death. So there are a number of principles that I would recommend that we try to follow. We try to involve the patient fully. They're really a partner. Sometimes we don't always know what to do. It's not always clear-cut what treatment to provide. So it's a discussion, a negotiation. We try to get a caretaker involved as well, because sometimes the patient is so anxious or nervous or upset, they don't hear all the advice that we have, so we like an objective ear listening in. At some point in time, we do address aggressiveness of treatment. We do talk about healthcare proxy, power of attorney issues, resuscitation, DNR issues. These are very appropriate. We don't talk about them on the first visit, obviously, but over time, we do talk about them. We want patients to be prepared. We try as best we can to get that patient to live independently, to care for themselves as long as they possibly can. So we look at what they might need in order to accomplish that. Next slide. We look at confidentiality. We try to get people to disclose to their family, to their sexual partners, to someone close to them, someone they can trust. You cannot go through this disease by yourself. Those who do have, it's been a miserable existence. I can tell you, I've seen it too many times. So we try to get them to disclose. We try to get an idea of who knows about their HIV status. And one of the important things is we conduct follow-up at regular intervals. We're always looking for potential complications of the disease. If they don't happen, great. It's a great visit. How you doing? Fine. Good. Take your ACT. Yes. T cells counts, they're up. Your CBC, it's stable. Good. See you next month. It can be very routine. But we do it on a regular basis. It gives the patients security. They know that we're there. They know they have a scheduled appointment coming up. It creates a very good atmosphere, I think. And so regular follow-up is it. They've got to know where they can go for help, who to call, etc. Okay, next slide. All right. Well, why are we doing all this? I mean, you know, I've heard people say AIDS is a terminal disease. Who cares? They're going to die anyway. That attitude is very prevalent in society. Remember the statistics I talked to you earlier about survival? When we give AZT and aerosolized pentamidine, the median survival is increased to 24 months. Not 11 months for men, not 8 months for women, but increased to 24 months. And in fact, 50% of people are still alive at 2 years. Okay. And this average, no therapy, 12 months. So we're doubling life expectancy. And this is old data. This is treatment standards, you know, in 1987, 1988, et cetera. We're doing even better than this now. Okay, next slide. Okay. AZT works. It slows progression of the disease. It slows it by at least 50% in people with advanced ARC and AIDS. It may even do better than that for people who are asymptomatic. We now use a T4 count of less than 500 in order to start AZT, and through studies that we were involved with, 500 milligrams of AZT a day is equivalent to 1,500 milligrams with a lot less toxicity. So AZT got a bad rap in the beginning because we were using higher doses. We now use 500-600 milligrams a day, and we have the same effect. Okay. So AZT works. And is it a cure? No, it's not a cure. Patients will still progress, but we are slowing their progression down significantly. Next slide. All right. Well, one of the issues, we slow it down, but we don't stop it. Well, why? Well, the virus is interacting. The virus sees the AZT, and eventually the virus outsmarts it. And so over 18 to 24 months, resistance or less susceptibility to AZT is seen. And so we're struggling with this question now. One of the reasons why we treat tuberculosis with 2 drugs is because resistance develops when you treat with only 1. So that same concept is now being looked at in HIV disease. If we give combinations of treatments, will we prevent resistance from developing, and will patients do better? I don't know the answer to that yet, but we will have an answer to that question within the next few years. What we do know is that we have alternative drugs. If you're on AZT for 2 years and your T cells are starting to go down, you're not feeling well, and we think the AZT is not working as well anymore, we can now switch you to drugs called either DDI or DDC. DDI is now available by prescription. DDC is still experimental, but I would expect it to be available by prescription within the next 6 months. Okay, next slide. So we're still struggling. Well, how do we know DDI works? Okay, you can ask me that question. And the answer is DDI and DDC both are the only other medications besides AZT that has been shown to raise T cell counts and lower P24 antigen levels. Counts go up on DDI. The toxicities for DDI include pancreatitis and peripheral neuropathy. And because DDI is metabolized to uric acid, a hyperuricemia is very often found. Okay, next slide. But we haven't had anybody develop gout, by the way, just hyperuricemia. DDC, the same thing. Side effects a little bit similar. Peripheral neuropathy, a little bit more severe than DDI. So we're trading off. AZT side effects include hematologic side effects. These drugs do not have very much hematologic side effects. They have other side effects. So finding the right drug for an individual patient is something that an exercise we go through now. These drugs are being compared, both DDI and DDC are being compared in studies to AZT directly, and we'll have results of probably both of those studies later on this year. Okay, next slide. Okay, so let me summarize the framework I've just presented to you. It's a clinical framework, and I go through these 5 things each time I see an HIV patient, whether it's my first time seeing them or my 50th time seeing them. I want to know, where is their immune system at? What staging? What's their T cell count? How are they doing with that? Intercurrent illness. What's going on? Are they having symptoms? Remember, HIV patients get non-HIV related complications too. They can have an MI. They can have appendicitis. They can get regular diseases just like non-HIV people. They just can get a whole nother set of diseases as well. So your differential has to be broader for someone who's HIV positive. What kind of things can be prevented? What's with their prevention screening? Are they at the level where they need preventative kind of treatments? Next slide. We talked about counseling. What are the kinds of counseling issues that should go on? For women, we talk about the possibility of having an HIV-infected child, because that is a very important discussion. And then finally, we decide what kind of treatment. If their CD4 cells or T cells are below 500, do we start treatment? And if we do, what kinds of treatment are we going to use? Are we going to use AZT? Are we going to use combination? Are we going to use DDI, etc.? Right now, the standard is AZT. Any primary care physician should be able to prescribe AZT. That's my feeling. You do not have to send your patient to ask me whether or not they need AZT. If the T cells are less than 500, put them on AZT, and then if you're a little nervous, then send them to me. But don't wait, okay? Get them started. I knew you were going to ask me this question, so I put it in here. And I'm sure you're going to have more questions when we open up for questions. But the transmission of HIV, it still happens in 5 ways. These ways have not changed, despite the dental cases in Florida, and despite a lot of hoopla, etc. The modes of transmission still have not changed. They are homosexual and heterosexual contact, sharing needles and intravenous drug use, from mother to child in the perinatal period, rarely from the transfusion of blood products, and rarely from mucous membrane or needle stick exposure. They have not changed. Once I was listening, I was driving home from the hospital, and I was listening to the radio, and they had this, talk show on AIDS, and people were calling in, and I had a cellular phone. And, the talk show host goes, who knows how much we really don't know about the transmission. Then I find that irresponsible journalism. So I called in, especially after the man asked me the mosquito question. I just couldn't stand it anymore. I thought we had answered those questions 8 years ago. So I had to answer the mosquito question. It really got to me. The transmission really has not, the transmission modes really have not changed. We can talk about the dental case more if we really want to. That's all I'm going to say about this for the time being. Okay, next slide. All right, so here's what's going on. They're looking at HIV in the brain because some people are becoming demented. How is that? Is there different? Are there kinds of viruses that do that more than others, etc.? A lot of work is being looked at HIV infection in the brain. In fact, probably HIV gets into the brain very early on in the infection, but doesn't cause trouble until much later. HIV replication in the lymph nodes. The lymph nodes is where T cells congregate, and so a lot of interaction is going on, cell-to-cell communication, in that microenvironment of the lymph node, and that is being studied much more actively now. We've kind of come full circle. We used to study it, then we went to blood tests because blood was an easy sample. Now we're going back to studying lymph nodes as the site of HIV replication. We're looking at monocytes. I've talked to you about T4 cells. They're lymphocytes, but monocytes also can be infected with HIV, potentially carry it into the CNS, and represent an important reservoir of the virus in the body. And so we're looking at monocyte function. And then we're looking at the regulatory genes of HIV itself. HIV is a complicated little bugger. And it's possible that if we can figure out all the complex steps that it has, we'll be able to fool it. And that is really the hope with future directions in research. If we learn more about how the regulatory genes, HIV has its own proteins to direct the cell to make more HIV. If we can provide drugs that can affect those proteins, we'll also have an impact on the disease. And I remain optimistic that more information is going to be learned about this, and newer drugs as a result are going to be developed. Okay, next slide. All right, well, what are we doing at ECMC? We're an AIDS-designated center. Well, what does that mean? That means that we get an enhanced Medicaid reimbursement rate from the state health department as a result of providing a comprehensive program. Any hospital can become an AIDS-designated center. All you got to do is meet the 13 standards that they publish. The goals of the center are to improve access and quality of care, to provide for a full continuum of services, and to act as a medical or educational resource. I give lectures like the one I'm giving tonight all year long. Next slide. Very happy to do it. We have a very important part of our component is case management. We have, right now, we have 4 social workers and 2 outreach technicians working solely to, and a nurse who work solely to coordinate care. We conduct clinical research, and we provide both inpatient and outpatient care. We have educational experiences, and we're very active in the community. We're involved with the AIDS Network of Western New York, and I recognize a few of you from that process. Okay, next slide. One of the things we do have is we have an AIDS clinical trials unit in upstate New York. This is a tremendous asset to our program because it allows access to new drugs and research protocols. It's a nationwide network, and the benefits are that by enrolling a large number of patients, you can accumulate data very fast. Plus, people all over the country can then have access to these protocols. And we're very lucky to have the unit here in upstate New York. Next slide. And it is sponsored by the University of Rochester, and SUNY in Buffalo, and the SUNY Health Science Center in Syracuse are satellites of the Rochester unit. And together, we have made a very successful unit. We're the 8th largest unit in the United States, which is pretty good when you put us up against the competition. So I'm very proud of that record as well. It's been one of my other jobs for the past 4 years. There's just a slide on the AIDS network to show that there is a broad-based coalition of agency representatives and people with HIV who are meeting to discuss the needs of people with AIDS in all 8 counties of Western New York. I know that there are people from Wyoming County who are participating in that effort. I encourage more of you to get involved if you're interested. There's so much more that could be done to address the issue. Questions?
How about the AIDS case in Florida? Which you thoughts about that?
The AIDS cases in Florida.
That one. Kimberly Vergalis?
Right. The CDC took the whip-out approach, if you ask me, and that is because they could not definitively ascertain the mode of transmission. They published, horrendous guidelines, very controversial situation, etc. But in fact, most people believe, who have also investigated these cases, that it was a breakdown in infection control procedures that resulted in the potential transmission. It's still not exactly clear that the transmission occurred. The scientific evidence is still a little shaky. But if you say, okay, we'll accept the scientific evidence that the transmission did occur, it appears that in that particular dentist's office that proper infection control procedures were not being followed, that proper sterilization and cleaning of his equipment was not happening between patients.
The operator, can we please call the operator?
He also had his own teeth cleaned, etc., with his own equipment. And this, I believe, has pretty much been the position of the American Dental Association, and at least to most of the independent investigations. Unfortunately, I was very disappointed in the CDC's ultimate report because of the lack of absolute scientific certainty and the inability of the government to therefore not be liable. They took the approach that they couldn't say exactly how these cases were transmitted, and that individual institutions have to decide this for themselves, which is really kind of absurd. So most of us believe that that was an anomalous situation, that a dentist's office that follows proper infection control procedures is a safe place for people with HIV and without HIV to be seen. And that's certainly been our experience in Buffalo.
The reason they can't find any medication for, really specific for the AIDS virus, and they can't find any active or passive vaccine therapy for this?
Well, that's a complicated question. The drugs that we have available are specific for HIV. However, some of the side effects relate to the fact that we're dealing with DNA and RNA, and so there is some affinity to human enzymes by those drugs. But they are HIV specific in the fact that they are working against the reverse transcriptase enzyme, which is a viral enzyme. It is not a human enzyme. Many other drugs are being looked at that work at other proteins of the virus that are still in very early stages. And so they are viral specific. But you're dealing with, when you're dealing with HIV, you're not dealing with just one virus. You're dealing with a swarm. Think of it as a beehive. And out of all of those bees, there's going to be one that's not going to be susceptible to the drug that you've got. You kill all the rest, that one's going to multiply. And that's basically what happens. So our drugs have to do better than what they're doing now. But it's also because HIV is a swarm within the body. It's not just one virus. In terms of passive and active immunization, there are a tremendous number of research going into this area. Looking at, there are at least 12 different vaccines that are being studied in one level or another in clinical trials. The problem is because the virus is changing, its GP120 molecule, the outside shell, changes. And so, is your vaccine going to work to prevent all the different kinds of GP120 that are out there? That's a major question that's yet to be answered. So they're working on it. Very feverishly, they're working on it. But it's a tricky little bugger, and it's going to take, I think, some time before we have what we really feel is a confident vaccine.
You said that this is a new disease, it wasn't present here before?
That's correct. The first evidence of HIV positivity within the United States in a broad-scale way was in 1976.
They said it's present in Africa.
In Africa, and there are case reports in the literature that are consistent with the AIDS definition that go back as late as the late 1950s. So it is possible that it was there in the 50s, and then once it got on a fast track, it became a worldwide epidemic.
It was a transmutation or something from a virus? Or?
If I knew the answer, they'd be giving me the Nobel Prize.
Is that virus different, the African virus?
There are two major strains of HIV, HIV-1 and HIV-2, and there are minor variations within individuals, but HIV-1 is HIV-1 all over the world.
Because most of their illnesses are diarrheal as complications. They call it SLIM in Africa. The people who have AIDS, they're called SLIM. The disease is, quote unquote.
We have a lot of slim people in Western New York. It's just that they don't get some of the other ones because they're so malnourished to begin with. There's just a different set of living circumstances there. But I don't think the disease is that much different. There's Kaposi sarcoma, there's pneumocystis pneumonia, there's cryptococcal disease. The only thing is there's malaria, there's babesiosis, and there's all these other things that are, specific to Africa that aren't very much in Western civilization.
Yes, would you speak to the idea? There was some information that has come out lately about the transmissibility between using men and women, okay, saying that the chances of women getting the AIDS virus is greater, much greater, in fact, than men picking it up, and we're talking about in heterosexual relationships. And I cannot for the life of me understand why they ignore the African model that has been well established, that in a society where we take out homosexuality, we take out drug abuse, and then we look at numbers, where that's heterosexuality is the risk. And what do we have? We have the same number of women, the same number of men with the disease. You know what I mean? And so I think that we're lulling people into this country. Some of those statistics was coming out around Magic Johnson about how hard it is for a man to get the AIDS virus from a woman. Gravy, here we are trying to keep safe sex, and we're having somebody diffuse us. It's just women that have to worry about picking up the disease in a sexual situation. What? Well, speak. I want you to speak to the statistics now. Okay. How could it be? How could it actually be?
You're dealing with a different culture.
No, I'm not talking about culture.
No, but it is important because
we're talking about men and women having sex.
Yeah.
And we're having men and women having sex. And we're having exactly the same men
what you're talking
as women. Your slide showed it, 40-40.
You're not even letting me answer the question.
Okay.
I see you feel strongly about this, and
well, I think that we're trying to educate the public here in the community, and we're being diffused by people that are saying that men's not going to get it from women. It's really just women are going to get it from men. So
you have an interaction with multiple sexual partners, with prostitution, which is extremely high in Africa, and with virtually polygamous, in many cases, polygamous societies. So that has contributed greatly to the nearly one-to-one incidence of HIV within Africa. I do think that on a purely scientific basis, that it is probably going to be more efficient transmission from male to female than from female to male. That is not to say that female to male transmission does not occur. It does occur. Whether it occurs in equal frequencies, that's a scientific fact. It's not really relevant because the point is you can still get it. I mean, it's not like you can't get it. You can still get it. So you're right, focusing on the fact that that it may be less efficient from female to male does not nullify the fact that transmission definitely occurs in that direction. And so I agree with you 100%. Is the transmission truly one-to-one? I think you're talking about some societal differences there when you compare African society to Western society. But clearly, transmission does occur from women to men, and that has ramifications for people who, in this civilization, who are using a high number of sexual partners, who are using prostitutes, who may in fact have drug abuse or other significant HIV risk or infection, etc. So those statistics should not be used to pacify the need for safe sex, etc. Not at all. I agree with you. Really, I agree with you 100%.
Yeah, you know, it's just a young man who has been told by the media his chance of getting it from a girl, a woman, is so rare that then, of course, he's not at all obligated to put on a condom. Because, you know,
well, this is why we can't depend upon the media to teach our children these things. We have to do it ourselves.
Yes, but the problem is that sometimes they're quoting what appears to be, for the public, really good facts. You know, they think that they're drawing it out of really good facts, and I think that we're, you know, we've got a model here, and just like you're saying, we've got, this has got to be a whole circle of safe sex. We can't have safe sex for one half of the party.
Right, doesn't work. Absolutely right.
How about prophylactic AZT? Once you have a positive test for HIV, without relying on the T4 cell count, starting on 40 T cell count.
Okay, everybody hear that question? That's about prophylactic AZT, regardless of the T4 cell count. Well, that issue is being studied right now. It's a risk-benefit issue. For someone who's asymptomatic, whose T cells might be stable for a number of years, is it worthwhile to put that person on ACT? The risk of treatment may outweigh the benefits. So a study is ongoing at this time, the results of which are still not in yet after about 3.5 years, looking at people who have greater than 500 T cells who are randomized to receive either AZT or placebo. So that is potentially a reasonable thing, and we might come to that once we have the data to support that, but right now we don't have the data. If I have someone who's symptomatic who has greater than 500 T cells, I will treat.
But do you count only this T4 cell or you count the T8 along with the ratio?
We do the T8s and we do the ratio, but they're more for academic purposes and for practical purposes. The practical value is the T4 count itself.
Just the absolute one, no, you know, significance of the ratio between T4 and T8?
Any viral infection will upset your T cell ratio temporarily. So using T cell ratios as a screening device is really not a very cost-effective move. Very early in the disease, people can have a normal ratio and be HIV positive. Later on, they can have normal T4 cell counts, but their T8 count be up, their ratio be down. So we don't really depend on the ratio as much anymore. We're really focusing on the antibody test in combination with the T4 count itself.
How long is it going to be before the HIV infection, not AIDS, becomes a reportable disease so we can do a better job of surveillance?
Well, I can tell you that for states that have it mandatorily reportable, testing has plummeted for fear of confidentiality concerns, etc.
Then when is society, I guess, when are we going to get society turned around?
Uh-huh.
I mean, we tested for syphilis forever, you know, even when it didn't matter.
Well, that'll happen when HIV is not a stigma. When it's not a stigma, when it's okay to be a homosexual in this society, when drug abuse is recognized not as a personality flaw, but as a medical illness. We're a long way from both of those things happening right now. There are very few states in the country that have HIV testing results as mandatorily reportable, and what it has done, it has put a great decrease in voluntary testing. People are not going to be tested for fear that they're going to be put on a list. So, the state of Colorado, the state of Arizona have these mandatory HIV testing programs. People are going to California to get tested. They're going out of state to get tested. They won't get tested in those states.
All states makes it.
So the new CDC definition of AIDS will be T-cell count of less than 200 and HIV positivity, or the old definitions of the various complications. That will go a long way to giving us an idea of how much advanced HIV disease is really out there. It will not obviously satisfy it won't count every person, but it will give us a much better idea of how much advanced HIV disease is out there. Sometimes HIV patients die of non-HIV related causes, so you don't know about those people. But the new definition will go a long way to increasing a better understanding of the nature of the epidemic.
Did they reverse, I can't remember, I think they did reverse where they're going to require physicians to propose whether or not they were HIV positive? Looking for something on the CDC along the CDC, were they saying that doctors had to be tested?
That was voluntary.
It
is up to you.
That may have been one of the proposals, but that was definitely not adopted. Not adopted at all. Not adopted at all. Thank you.
Cheers.
Which is changing, the genome of the virus or the shared protein and phase of this information? How much of it is expected?
The genome of the virus does change. There are variable regions of the genome. There are at least 3 different variable regions in the GP120 protein, and there may be variable regions in some of the other proteins as well. So the genome of the virus does change in response to its environment.
How much this is a problem to all of the vaccine?
It's a significant problem.
What is the
Significant.
prospect of the world vaccine?
I think within 10 years it's very reasonable, but a lot of obstacles are going to have to be overcome. I mean, we're already now into 12 different vaccine products. So we're looking at the study. The issue is under tremendous study. It took 8 years to develop the feline leukemia virus vaccine for cats. It's taken us, and that's a retrovirus, an RNA virus, not very different from HIV. It's going to take us at least that long.
I think there is a little time to see how it can be determined that this particular patient is from this time. There must be a match.
That's a headache for the man who has to design those vaccine trials. That's a very difficult question. Very difficult. There's another question over here.
Yeah, it's been brought up repeatedly that the more virulent virus ends up being selected out as disease progresses. Is there any indication that a more virulent virus or a more durable virus is becoming generally available to the population, or is it pretty much kept to the patient?
It's pretty much kept to the patient because they're so sick. By that point in time, they're not having sex anymore. Sometimes they still share a needle, so that's a concern. But they're not donating blood, certainly. So it's not as great a concern. One of the concerns is resistant viruses being transmitted, which could potentially occur while a patient is still relatively healthy after having been on ACT for several years. That is an issue that I think will, the resistance issue will probably become more important rather than the virulence issue in terms of transmission.
What's your protocol at ECMC for needle stick for this staff over there
Okay.
working with HIV patients?
Our protocol is as follows. It's a long answer, so I gotta give it all in the right order. A needle stick, we consider a needle stick injury to be an immediately reportable event. We do not wait till the end of the shift. You know, we do not tell the supervisor the next day. It is an immediately reportable event. At that point in time, the person is assessed by their immediate supervisor, and we try to get an accurate description, as calm as we can, because usually the people are very upset when it happens, as to what exactly happened. Very important thing to do. We use our employee health department during the day. We use our emergency room at night for that purpose. At that point in time, depending upon the nature of the exposure, the person will be offered the possibility of ACT prophylaxis. ACT prophylaxis is not proven to be efficacious in this setting. However, we have considered it ethically unacceptable not to offer that as a treatment option, knowing that the long-term risks and benefits are not really known. We provide a 72-hour supply of ACT. We have it prepackaged by our pharmacy, ready and waiting in the emergency room and in employee health. We then expect, either through workman's compensation or through their insurance, the remainder of the ACT prescription, which is prescribed for 4 to 6 week period, to be filled. Usually that person will get into follow-up, usually with me, and we'll follow that person for HIV. They will have a baseline HIV test, they'll have hepatitis screening, they will be given the hepatitis vaccine if they haven't already received it. And that is from a known HIV source. From an unknown HIV source, we will attempt to test the patient, but obviously you can't force a patient that does not want to be tested. We will try to assess the risk in the patient as well, and many times we will not necessarily treat, we'll just observe. We do HIV testing at baseline, 6 weeks, 12 weeks, 6 months, and 12 months. At 12 months, we give that person a green light. At 3 months, we give them the light. We give them the pretty much green light. I mean, because after 12 weeks, if you haven't developed antibody, there's a tremendous likelihood that you never will, that you weren't infected. We definitely talk about safe sex precautions during that time. Usually, that person isn't touching their spouse for the next 3 months, and that's basically how we do it. I've treated nurses, surgeons, dentists. Those are the main concerns.
Any conversions in your experience?
We've had, I have 2 patients that I have treated, potentially. They weren't employees of ECMC at the time, that they may have had an occupational exposure, one a physician and one a nurse. And one of the most famous cases occurred at ECMC, received a lot of press several years ago. The woman now lives in New York City, where she was stuck with a syringe during the code, in which she received a significant mini transfusion, and sued the doctor for negligence. For improper handling of the materials during the code. It was a known HIV patient. So that's how we handle that issue. Universal precautions, we've done a tremendous amount of work with universal precautions. We have a needle disposal unit in every patient room. We have a glove supply in every patient room. We have carts that contain gowns, masks, etc. Very easily located on every nursing unit. We consider every patient to be HIV positive until otherwise proven in terms of how we handle samples, etc. Everyone uses gloves for venipuncture, for starting IVs, for any kind of procedure, for doing wound and dressing changes. We wear gloves. We make the gloves so easily available that it becomes very easy. It's very easy to grab for the box, put on your gloves, do your thing, take the gloves off, wash your hands, go on to your next case. That took a certain amount of expense for as a hospital to do as a policy, but it's proved a very valuable policy. We use universal precautions in addition to respiratory isolation and strict isolation. Those are the only categories we maintain now. We do not use blood and body fluid precaution signs anymore. Everyone is on blood and body fluid precautions. We do not use wound and skin precautions because everyone is on wound and skin precautions. We only use respiratory isolation and strict isolation. Everyone, those are the only two isolation categories we use now. We have done away with the pink, they used to be pink, blood and body fluid precaution signs. We found them to be stigmatizing because almost always they indicated the patient was HIV positive. We don't use them anymore.
Difference in the hollow needle and the solid needles.
I'm sorry, I can't.
Any difference in precautions if you use the hollow needle and the solid needle in the OR?
In the OR, the solid needle is definitely the preferable instrument. Double gloving is recommended. Almost all of our surgeons double glove. Double glove decreases your dexterity, so it slows down the operation,
Your attention, please. Visiting hours are over
Very
throughout the
smart
hospital.
practice.
Your
If you don't
attention,
do
please.
it, as a
Visiting hours
surgeon,
are
I
over
highly
throughout the
recommend
hospital.
Very
Thank you.
uncomfortable. The operator.
In the operating room, there's a number of procedures that we follow. We generally schedule HIV patients as the last patient in that OR so that it can be cleaned properly. The surgeons and the OR team discuss the operation in detail, what is going to happen. Dirty instruments are not passed from the surgeon to the nurse. They are put on a tray. So there are changes that have gone on in the way that our surgeons operate to reduce risk in working with patients. And they've been very successful, and I've been very pleased with the response we've gotten from our surgical staff. We have very few surgeons who ostensibly are not willing to take care of HIV patients.
What type of gloves you use? What type of gloves?
Latex.
You
Latex.
know the labels?
I don't know the brand. They're all the same to me.
Is there any?
The most common musculoskeletal manifestation you need AIDS patient Neoplasia.
It's myositis, myalgia, and sometimes they get arthritis too.
How about unusual bone infection? What goes by the feet?
Hey, anything can happen. That can happen. We've had cases of atypical mycobacterial osteomyelitis. We've had histoplasma osteomyelitis. Salmonella can be seen in HIV patients at an increased frequency. Any other questions?
How about aerosols in the operating room, especially with orthopedics? Have you guys addressed it at all, if you have?
Aerosolization is not a mode of transmission for HIV.
I think that's still on the table, isn't it?
It is in Lorraine Day's mind, but not in anyone else's.
She's very convincing in her...
Oh yeah, oh, you can see the clouds and all that stuff. There's just no evidence to support it. None whatsoever.
Okay, so that says that in fact, you know that as a group, orthopedic surgeons are being tested, and you know that they're not becoming HIV positive, right? Because
Right.
that's the only way you can actually.
In fact, they tested all the orthopedic, well, not all of them, but many of them at one of their conventions recently,
And that's really important.
and they were all negative except for people who had a known risk for HIV.
Because I've never seen those statistics, you know, and she's very vocal.
Oh, she's tremendous. She's tremendous. But she is a voice in the wilderness at this point in time.
What about the transmission of the virus through the milk and saliva and tears?
Through breast milk, I assume when you mean milk. Women who are infected at the time that they are secreting can in fact secrete HIV into their breast milk. Women who are positive for a number of years, who have a baby, who have breast milk, evidence from the third world is that that breast milk contains very important antibodies and that the babies actually do better getting breastfed than not getting breastfed. So it's infection while they're developing breast milk, that is important. That period of viremia that I showed you, that can bump into the breast milk. Saliva, tears, no evidence for transmission from those fluids, despite the occasional isolation of virus in them.
What precautions, precautions and method of antisepsis do we have for anesthesia, machines and things like that?
Soap and water goes a long way. Any disinfectant solution will work. That's the answer. Soap and water will work. Sidex, you name it. Now, there are certain solutions that do not pass bacterial sterilization standards that you should be aware of, but they all work for HIV. It's a very easily killed virus on surfaces and in machines, etc. So any disinfectant, will work.
And how specific is this HIV testing? Is it absolutely specific or just
No test is
non-specific?
No test is 100%, but HIV antibody testing is over 98% sensitive and over 98% specific. So it is in general a very accurate test. And in New York State doesn't even trust the antibody and makes you get a Western blot as confirmation. They do the Western blot as confirmation. Many states in the country don't even do that. They just accept the antibody as enough.
What is the dosage for your prophylactic?
We use 600 milligrams a day, 100 milligrams every 4 hours.
What is the cost of the treatment of that ACT?
ACT costs approximately $1.25 a capsule.
And you're receiving it how many times a day?
So you get that's a 100 milligram capsule costs about $1.25, and you take 5 to 6 a day. So that's your cost. About $9 a day.
And is there any organizations that have helped as a greater cost for the families? They were in
Yes.
lower income?
New York State has a program called the AIDS Drug Assistance Program that will provide ACT and other medications that are specific for HIV disease if they do not have Medicaid and do not have medical insurance that covers prescriptions.
What's the name of it again?
It's called the AIDS Drug Assistance Program, the ADAP program. It's been a very successful program, and it's paid for by federal funds. Okay, can I go home now?